Good evening to everyone and welcome to today's session. Today is December 12, 2019, Thursday. This is Dr. Murli Bharadwaj, your everyday companion in learning. I study for 2 hours, you study for 2 hours. We will share what we both have studied because I am your everyday classmate. So let us quickly rock the show with some of the favorite high-yield areas for the tomorrow's exam. So what do you see here, Doc? Sausage-shaped fingers because there is dactylitis. And what do you see here? There is a pitting keratolysis. You are able to see pitting keratolytis, right? So what am I talking about? I am talking about psoriasis. This is another classical feature where you are able to see that there is onycholysis in a case of psoriasis. Then this is another example of onycholysis, classical appearance in the case of the psoriasis. Tomorrow's NEET PG exam, when you get a image-based MCQ, ditto, don't ask me, doctor, that I told you before exam. Of course, my job is to tell you before exam. So, now the 5 points about psoriatic arthritis. Let us get very clear about it, doc. Psoriatic arthritis, what percentage of cases of psoriasis have it? Only 5 to 30%, at least good news. It is the dip joints which are involved in psoriatic arthritis. Morning stiffness, deformity, dactylitis leading to sausage fingers, nail involvement with onycholysis, a well-demarcated red block with a silvery scale. These are the classical features of psoriasis. So on every topic, doctor, at least 5 to 10 points you should have in your own pocket when you go for the exam tomorrow. NSAIDs, methotrexate, anti-TNF agents, they are all used in the treatment of psoriasis. Now, doctor, what is this in the peripheral smear? Tomorrow's NEET PG, they are going to ask you, they will give you one slide and show you the smudge cells. With the help of that, you should recognize. Now, what are the 5 things that will be there in your pocket when you go for the exam tomorrow? Typically in CLL, the diagnostic criteria are very important. How much will be the peripheral blood lymphocyte count? More than 5 into 10 to the power of 9, usually more than 10 into 10 to the power of 9. A B cell specific antigen, CD5 plus. You should not forget when we talk about the CLL. Good to see Sweta and some of the friends who are all online. Dr. Extempore, whenever I get the time, I deliver one flash session, 20 minutes, 30 minutes session. So subscribe to the YouTube channel so that you will get the notification. So that is the idea. So until January 5th, we are all in a war mode. Every time we get opportunity, we do revision. Okay? Now, a bone marrow aspirate in CLL, more than 30% lymphocytes. CLL also has an association with an autoimmune hemolytic anemia. Autoimmune thrombocytopenia is what you should remember. The patient can have hypogammaglobulinemia, hypergammaglobulinemia. Some of them can have monoclonal gammopathy. So please don't forget, doctor, diagnostic criteria for CLL is a favorite area, especially CD5 plus is the number which you should not forget. Very elderly people, 70-year-old, 80-year-old. In logo में, what is the most common leukemia, doc? CLL. CLL is a B cell leukemia. CLL is a B cell leukemia. You find smudge cells on pathology. Can everybody punch whether the lines are clear or not? Or the letters are big enough for you or not? Yes, now this is better. Smudge cells on pathology. So what are smudge cells? In CLL, whenever you are preparing the smear, there is a fragility of the cells. So that is the reason they undergo a partial breakdown. And because of that partial breakdown, you get a cell look like this. So this is called smudge cell, is what you should remember. Good to see Sada Khan, Shweta, and few more who are all online. Now, one of the favorite questions of the examiner, doctor. Tell me a poor prognostic factor in a patient of CLL. If a CLL patient is showing thrombocytopenia, that means it is a stage 4, which is a poor prognostic factor. So CLL presents with lymphadenopathy, splenomegaly, anemia, thrombocytopenia. Average lifespan is very good, 8 to 10 years. Already the patient is about 70 or 80-year-old. And CLL of all leukemias has got a good prognosis because the average lifespan after diagnosis of CLL will be about 8 to 10 years is what you should remember. Tell me, doctor, when you look at this peripheral, slide, what are you looking? You are seeing abundance of plasma cells. So, when you are seeing what you are seeing here, you are seeing the lytic lesions, doc. Lytic lesions. So, आपको यहाँ lytic lesions दिख रहे हैं, और you are seeing plasma cells abundance. So, what am I talking about? And you can also see multiple lytic lesions, and here you can see presence of a fracture. So, multiple lytic lesions and the fracture. So, what is your conclusion with all that? We are going to talk 10 points about multiple myeloma. So, doc, multiple myeloma, how do you like to describe? Monoclonal proliferation of plasma cells. More than 3 grams per deciliter of M protein if you do the electrophoresis. More than 10% of plasma cells in bone marrow. Shweta rightly recognizes that this is multiple myeloma. Absolutely. So what is CRAB in multiple myeloma? Hypercalcemia, renal impairment, anemia, bone pain, lytic lesions, fractures. Classical of multiple myeloma. Then in multiple myeloma, there is an increased risk of infections. Why? Because multiple myeloma is a monoclonal gammopathy which is overproducing the immunoglobulins, but they are all dysfunctional immunoglobulins. They are not functional. So that is the reason there is a increased risk of infection, which is a major cause of the death in case of multiple myeloma. Now comes the favorite MCQ of the NEET PG examiner. Monoclonal gammopathy of unknown significance. How do you diagnose? In them, the M protein is elevated, but it is less than 3 grams. If it were to be more than 3 grams, it would have been multiple myeloma. Less than 10% plasma cells only, but to call multiple myeloma, you need more than 10% plasma cells. 1% per year of risk of progression to multiple myeloma is what you should remember. So, मेरे प्यारे डॉक्टरों, आप ये भूलना नहीं. Monoclonal gammopathy of undetermined significance, smoldering multiple myeloma, active multiple myeloma. What is the difference? It all is the clonal bone marrow देखे तो clonal plasma cell concentration is a determining factor. If it is less than 10%, it is monoclonal gammopathy of unknown significance. 10 to 60% is smoldering, more than 60% bone marrow liye to more than 60% is an active multiple myeloma. Similarly, CRAB criteria. What is CRAB, doc? Calcium, renal impairment, anemia, bones. The CRAB criteria, if you take CRAB criteria, it is there only in multiple myeloma. Okay? Then progression to multiple myeloma, more than 10% if it is smoldering multiple myeloma. It is around 1% if it is MGUS, that will go into multiple myeloma. If it is MGUS, no treatment, only observation. If it is smoldering multiple myeloma, typically you have to, if it is a very high risk case, then only you need to treat. So that is a whole story. डॉक्टर अभी आ गया द नेक्स्ट हॉट चटपटा टॉपिक। आपको ये लंग का स्पेसिमेन देखे तो क्या दिख रहा है? व्हाट यू आर एबल टू सी डॉक्टर व्हेन यू सी दिस? सो यू शुड रिमेंबर, व्हेन यू सी दिस, व्हाट यू आर सीइंग? ए mass which is there in the lung, right? So this is a squamous cell carcinoma of the lung, gross appearance. This is another example where you are able to see a squamous cell carcinoma, gross appearance, how it looks like. And what is this area, doctor? This area is hilum. So what are you going to remember? Squamous, small cell. Squamous and small cell. Both of them are central. That is, they are typically present like a hilar mass is what you should remember. Now doctor, 5 points हमारे pocket में रहना tomorrow when we go for the exam. Even before examiner attacks you, you have to attack the examiner. You know very well, no? That is the deal with Dr. Murli. Squamous cell carcinoma is common in smokers. It is central and hypercalcemia because it produces parathormone like peptide. It causes weakness, dehydration, and you may see some desmosomes, keratin pearls. What are they? Keratin pearls are one of the important feature that you will see. Keratin pearls. You are able to see here, no doctor? I'll change the pen color. Yeah. Keratin pearls. This is keratin pearl. So this is how the carcinoma, which is squamous cell, percolates out and undergoes metastasis in case of squamous cell carcinoma. Now what are you able to see here, doctor? Very important observation. Have you seen? This patient is having a lighter. This is the cigarette packet, whatever, and he is also having a tumor. So this is a classical story of a 63-year-old man. 63-year-old man, he presented with cough, history of recent weight loss of almost 10 kgs, a very important finding. There is a 5.6 centimeter mass in the right lower lobe, a pack of cigarettes, and the diagnosis is what? Squamous cell carcinoma. Now, doctor, when you have seen this, what are you seeing here? Fatafat bolo, a mass lesion, you are able to see here. So this is a cavitating lesion. Once more, squamous cell carcinoma can present like a cavitating lung lesion. Any cavitating lung lesion should be in your differential diagnosis, squamous cell carcinoma. It is a non-small cell carcinoma, cavitating right lower lobe squamous cell carcinoma. So when you have done a assessment, what did you find out? Keratin pearls. Keratin pearls. This is how you should recognize in the histology in the tomorrow's exam, right? So once more we are talking about squamous cell carcinoma. Then what do you see here? Here it is a FNAC stain. So these are the typical small cell lung cancer cytology of the small cell lung cancer cells. And what kind of chromatin do they have? Salt and pepper chromatin. What is that called? Salt and pepper chromatin. A classical feature, nuclear molding. And why they are called small cells? Because if you compare the tumor cells of the other carcinomas, they are smaller. For example, adenocarcinoma. But they are relatively larger than most of the cells of the lymphoma. So that is the nature of small cell cancer. Small cell cancer cells. Now, doctor, comment about this. You are able to see a lesion, a mass lesion on the right side of the lung. So this is how a small cell lung cancer. Once more, it is also central in location. But what is the importance of small cell lung cancer? High incidence of metastasis is there in the small cell cancer. Small cell छोटू है ना, छोटू जल्दी भागता है. इसका एड्रिनल देखे तो एड्रिनल के अंदर भी मेटास्टेसिस हो सकता. So that is a point you need to appreciate. So this is how the histology of the, if you take the biopsy, a small cell lung carcinoma typically looks like. Now doctor, what do you see here? You are able to see some glandular structures. दिख रहे हैं क्या? Glandular structures है ना डॉक्टर? ग्लैंड के जैसे है स्ट्रक्चर्स, इसलिए ये है lung adenocarcinoma is what you need to remember. If you look at the adenocarcinoma, there are various varieties. Just like you have a Guntur idli, Baba idli, minimum mini idli. चेन्नई गए तो मिनी इडली होता है. Like that, adenocarcinoma में different varieties है, like masala dosha, simple dosha. So lipidic type, acinar type, papillary type, micropapillary type, solid type of adenocarcinoma, solid type, and you have invasive mucinous type. They are the various histological types of adenocarcinoma. So what do you see here, doctor? Typically in the periphery, you are able to see a mass lesion. So adenocarcinoma is also called scar carcinoma. Because of some infection, if you happen to get any scar in the lung, from that the adenocarcinoma arises, is what you should remember. Good to see Pravalika and many more. So you're all listening to flash session with Dr. Murali Bharadwaj. सो एग्जाम नजदीक आ रहे ना, इसलिए मैं भी आपके साथ आपके क्लासमेट बन के रोज पढ़ाई कर रहा हूं. जो भी मैं पढ़ाई करता हूं किसके साथ रिवीजन कर सकता हूं? आपके साथ ही बैठ के रिवीजन कर सकता हूं डॉक्टर. सो दैट्स द रीजन, इवन इफ यू आर इन रीडिंग रूम, even if you are in library, even if you are in hospital, anywhere, if you have a smartphone, you have a YouTube app inside it, you have the Dr. Murli Bharadwaj in your pocket, be very sure about it. So doctor, quickly tell me 5 points, how are we going to attack the examiner? So all the story is about how are we going to attack the examiner. Priyanka is saying, sir, I missed half an hour. No worries, no worries. After this session is over, I will once more host this video in the YouTube. These flash sessions videos we don't remove because basically this will also help us to do the marketing. भाई हम आपके साथ हैं, हमारे कोर्स में ज्वाइन हो जाओ, प्लीज ज्वाइन हो जाओ बोलने के लिए हम we use these sessions as a pep talk and ask you to join our larger video library. So that is the reason, don't worry, we won't remove this. We will typically put a advertisement inside this asking you to join our 2021 batch. You please tell your juniors to join our 2021 batch. Tell them that the best companion in the world who will actually hold your arm, your hand, your palm, and take you to become the topper in NEET PG, every day studying along with you, the one and only Dr. Murli Bharadwaj. Please tell your friends, your juniors, and ask them to join no one else but only with Dr. Murli Bharadwaj and make him the companion in the long journey, right? So, doctor, central hota hai small cell squamous cell, peripheral hota hai adeno and large cell. Smoking association, often adeno is not associated. That's the point. Cavitation is very common in squamous cell. Metastases are very early in small cell and adeno. Both of them are dangerous. Then very important, extra pulmonary manifestations. SIADH, ectopic ACTH, Eaton-Lambert, Cushing, peripheral neuropathy. All these things are very common in small cell. Adeno is associated with thrombophlebitis. Adeno is popular for thrombophlebitis. Squamous cell carcinoma notorious for hypercalcemia. Excellent. Shweta adds a very good point. Gemcitabine is used for adenocarcinoma. बहुत मजा आ गया. Very good. So keep punching those points. Each of you should have like a war ammunition. You should have with you the 20 points on each of these 953 topics. That should be your goal. You should play an offensive with the examiner, not a defensive. So it